Everybody, welcome to another episode of Injury Insiders. We have a special guest with us here today, Dr. Steve Smith. Dr. Smith, you there?
Yes, sir.
Awesome. We appreciate you taking the time to get on today. You have quite the accolade behind you, but before we get into all of your visual acumen, I want to talk a little bit about your upbringing. So if you could, give us a little introduction into who is Steve Smith. Where'd you grow up? How'd you get involved in orthopedics? What made you pick that as your profession?
Oh, well, thanks for inviting me. I'm from Central Kentucky, grew up in Anderson County, about an hour from Louisville or so. And from there, went to Western Kentucky University and played baseball there and graduated from there and went on to UK, where I did med school. After UK, went to Rochester, New York for my 5 years of training in orthopedics. And from there, went to the West Coast in Los Angeles to Kerlan Jobe, where I did my sports medicine fellowship. After all that was done, then Jennifer and I, my wife, we headed back to Kentucky and we started our practice.
Nice. So were you an athlete growing up? Like, how did you get into orthopedics?
Well, I played everything. I played, baseball, football, basketball, golf. And then, I thought I was a pretty good athlete till I went to college and I found out there's a lot better athletes than me. So, then I decided maybe I should pick up a book a little bit and read. And then so through athletics, I was always around injuries. I was around orthopedics and physical therapy and dealing with athletics and sports medicine, and just sort of got an interest in that. And then when I went to medical school, it became even more kind of pronounced as the direction I was headed.
Nice. It sounds like similar to mine. I only lacked talent and ability. Those are the only two things I lacked to make it onto the NFL. And
That and
apparently,
size, other than that, if I stood on a stool, I was good to go. Yeah.
yeah, that's great. So your education a little bit. I know you flew through your education. Tell me a little bit more about what you did out on the West Coast. Like, who are some of the athletes you worked with? Give us some more insight into that.
Well, and, we were fortunate, for me, I've been blessed to have tremendous training. Um, Great training through med school, great training through my residency, and then fellowship that you're referring to out on the West Coast with Kerlan and Jobe. And we were lucky to take care of a lot of high school kids and college kids, and certainly the professional level too, which it all has different perspectives and different priorities and who we're dealing with, from agents all the way down through parents, and everything in between, coaches, trainers, media. And then, specifically out on the West Coast, we took care of a lot of the college teams out there, and as well as the Dodgers and the Lakers and the Ducks and, the professional teams in that area. It was a tremendous experience. It was educational, much beyond just doing anatomy and orthopedics. It was an educational system and working with the team concept of everything that's kind of required. Time takes a village to take care of an athlete,
Mhm.
specifically in sports medicine. And once you begin to learn that and all the components have to work together to get someone back on the field, it's eye-opening. It's not just one thing that you learn, and it was more of an all-encompassing atmosphere. It was good. I was fortunate to be there.
Yeah, we talk about that a lot, about making sure that everybody's on the same page. You got the trainer who's got one opinion, you got the athlete themselves who has another, you got the PT who has an opinion, the orthopedist that has an opinion, and all those have to come together to decide return to play and protocols and what's the next step. Can you give us a little bit more into like some of the things that you saw out there that had changed in orthopedics? So, we're talking, you've been practicing now for almost 20 years, is that right?
Right.
Right. So when you first started versus now, what are some of the things that you've seen change throughout the profession, and which of those things do you think are trending the right direction?
Well, when I started, arthroscopy was kind of mainstream, but not as certainly mainstream as it is now. The ability to treat injuries and diagnose with the aid of an arthroscope using arthroscopy, with small incisions and cameras, is continued to get more and more advanced every year. So the from where we started from my residency using a scope to what we are now, what we can do through an arthroscope, with less invasive procedures is unbelievable. And, less invasive procedures in spine and joint replacements are continuing to evolve. Really, probably the biggest change, I think, as we're moving forward in orthopedics, we've got tons of implants. We've got tons of surgical options. We can basically have an implant for just about every injury, and we can fix every injury. And there's multiple options. There's multiple ways to do it. What I'm seeing as time moves forward over the last 20 years of practice, and then 6 or 7 years of training before that, is the biological enhancement of the healing. I think that's the next phase. Just every surgery we do involves healing of some sort. The body has to heal some component of it, whether it be an incision or the actual injury and the repair. What we're moving towards now is trying to advance the healing of that injury, or advance the healing of the surgery or the approach that we had to get into the body to heal it. So as time moves forward, I think that's what we're going to see over the probably next 10 to 20 years. Orthopedics is an implant-heavy profession. We're always going to see new options, new gizmos, new screws, new anchors, whatever, to repair something. But what I really think is going to happen is what we're going to find is biological enhancement of using the new anchors, perhaps even using old concepts to get the body to heal it better and whatever you're trying to fix. That's what's moving forward. And I think that's probably the cutting edge, the interesting thing that's going to be for the next generations of surgeons.
Yeah, that's exciting to us in the PT side, because obviously, just like you guys, we want to get them back to whatever they were doing as quickly as possible. And especially that first 2 to 4 weeks after, you're just waiting for the tissue to heal, whether it's bone, tendon, ligament, whatever, you're waiting for that to heal. And so the faster that we can recover that, the quicker we can get them, back into their activity. So I agree. That's exciting. So in terms of like some of your philosophy, because, a lot of people, like, they're afraid to go see an orthopedist because, like, man, he's going to want to do surgery on me. Can you give me some insight into your philosophy when it comes to assessing a patient for the need for surgery?
Well, as I'm becoming more of an aged surgeon, I kind of moving up letterheads and stuff like that, and getting a little older. I was just talking to
more refined,
younger
you
orthopedics.
Might say. Yeah. Not exactly. Age, but more refined.
Yeah. I was just talking to a younger orthopedic surgeon, and one of the things I've told him that's interesting, I think I've talked more people out of surgery than into surgery. When you have when you're talking about elective surgery, it's a huge decision for people. You have a financial decision, you have a social decision, and just the ability of timing whether or not an elective procedure is ready to go. And that's different when you have an emergency procedure or an urgent procedure, but elective surgery is a little bit different world. And the key thing is you got to try to put, the patient first, no matter what you do. If you keep the patient's wills and their directive, their desires, their goals as a priority, then you really won't go wrong. And then one of the key things to do is to incorporate their decision making in that process. Take time to listen to, if they had their upcoming daughter's wedding, they want to be scheduled around that, or they got a retirement come around, or they have this, or they have this. If you're a farmer and they get a crop in, or whatever the deal is. And, in talking about sports medicine, several of these things we can fix in the off season. We can brace them up, get them therapy, and try to get them through the season so they can finish out their year, and then repair what we can in the off season. Those types of decision-making processes are key, and you got to involve the patient in doing that. And when you put the patient first, it sort of fits itself first, because you'll just listen to what their goals are. You already know what the problem is. But the timing on fixing it and educating them on what's involved in the commitment to recover from the surgery is huge. As you know, as a therapist, oftentimes in the whole gamut of the recovery process, the surgery is sometimes the smaller component of it. The recovery can be way more in depth, more time, more expensive, and more painful, really,
Yeah.
than the surgery. Um,
Yeah.
that's what we were saying earlier. It takes a true village to do an orthopedic recovery. Um,
Hmm.
and the sooner you realize that, as a younger surgeon, the sooner you're going to realize your success is going to go up. It's not just you operate on them and you close shop. That's kind of just the beginning. And even before that, you got to figure out, if you're going to operate on what type, when, and how, and what the patient wants.
Yeah, absolutely. And when you talk about elective surgeries, for those who don't know, elective surgeries means this is not a life-threatening surgery that you have to have today to sustain life. You have the option to choose, do I want to get this rotator cuff repaired today, a year from now? Do I want to push it off forever? So that's the idea behind the elective surgery. And as a patient myself who's been to a few orthopedists, I definitely respect that, because there are multiple times where life is happening and fitting the surgery into it at that time just doesn't make sense. But having your input to know what the best decision is, it's nice to know that you're creating a space where you're basically an ally for the patient, and you walk through it with them to make sure that you're fitting it up to their livelihood and what works best for them. So that's awesome. It sounds like it's something you learned over time, as opposed to thinking like you always had to be the guy that had the answer. It sounds like you've kind of learned through that process. You got to walk through it with the patient to figure out what's best for them, based on all the information you have in front of you.
Absolutely. I mean, in this team concept we talk about for recovery, and the captain of that team, of course, is the patient. If they have something that's coming up in their life that is crucial, and that takes priority over things that is in the recovery process, it's going to be tough for them to find that balance, if we don't talk about that beforehand and let them either prepare and plan for that, or like you said, maybe put it off a couple of months and then do it when it's more cohesive to their livelihood.
Yeah, absolutely. So what all different types of procedures do you do there at Aptiva?
Well, for me in general, as I have moved forward over the last 20 years, the majority of my practice is knees and shoulders, um, and some elbows as well. As an orthopedist, you tend to see everything that kind of comes through from spine and back and foot and ankle and so forth. But as my practice has specialized over the years, I would say it's probably predominantly shoulders and knees with a few elbows.
Very good. That's good to know. So Steve, can we back up a little bit? Can you tell me a little bit about what brought you over to Aptiva? What was interesting to you about their model, and how's it been going? You've been here almost 2 years now, or a little over 2 years.
Yeah, it's about coming up on 2.5 years.
Okay.
And I came from a local private practice group, which was a phenomenal situation for me. I'm blessed to have that opportunity to practice there locally. Great group of guys. For me, this was just sort of a parallel move to me to a sort of a different system. Aptiva, I think, is more cutting edge on how they're trying to define their healthcare network. And for me, it was a good opportunity to kind of broaden my horizons and go a different path, still doing the same sort of treatment, same types of philosophies, and still with the same sort of a team atmosphere, just in a kind of a different setting. As I've been here, it's been great. I've been, like you mentioned, almost 20 years practicing in the Louisville area. And all 20 years have been great. And this is just sort of a next sort of stepping stone for me, which has been nothing but positive.
Well, we're grateful to hear that you're happy here, because we want to see you continue to work with us. We've gotten phenomenal feedback from patients, and they do mention the things that you've said so far, that you spend time with them in the rooms, you get to know them and figure out what's best for them, and you give them the facts of the situation. Here's what it is. What do you guys want to do? And you put the ball in their court. Like you said, they're the quarterback of this. And we talk a lot about innovation in healthcare here at Aptiva. And I think you talked about it a little bit earlier, that it's not always the technology that's changing that drives us to make a change, but it's just the way in which we approach it. And having that multimodal model where we're all under one roof, we're not siloed off, partitioned off, only doing one specific thing. We really do have to communicate effectively as a group. And so we definitely appreciate having you here. I had a patient the other day that said, well, if he's good enough for the Dodgers, he's good enough for me. And so, you know, you've got a great business acumen, and we definitely appreciate that. Is there anything that you'd give advice to either patients or people that are entering the medical field? Is there any advice that you have? Let's break those up. So, what advice do you have for patients that are, you know, debating whether or not to come see an orthopedist, or if they have pain, they don't really know if it's surgical, but they don't necessarily want surgery? You know, what advice do you have for them?
Well, to use a medical term, they say if it's truly affecting your activities of daily living, if you have a condition that is not allowing you to enjoy life, certainly changing your function where you can't take care of your duties at home, you can't work. Of course, that should bring you in. But in general, if the lack of function or pain is affecting your daily life, that it is taking your focus away from your family and friends and your job, you probably should at least get that evaluated and see what your options are. And then the first part of the question, what would I, tell other orthopedic young guys or orthopedic people or people want to go into orthopedic surgery? I would tell them one of the things that was told to me by Dr. Gorska, I was mentioned earlier, one of the great mentors I have. He was a orthopedic surgeon at University of Louisville, or I'm sorry, University of Kentucky. And I did research with him there when I was a medical student. He then became the head orthopedic trauma at University of Rochester, where I did my residency. Great guy, and one of the best surgeons I've ever worked with. And one of the things he always said, when the patient comes in, before you do anything, you want to make sure and shake hands and look them in the eye and see what their goals are, and see what their plans are, and see what they're doing. And then when you go out to, once I went to the West Coast and worked with Dr. Jobe, who invented the Tommy John surgery. And one of the things he always talked about was, if you listen long enough, the patient will tell you what's wrong with them, and you really don't even have to look at an MRI or an exam. If you ask the right questions, you've been around it enough, they'll tell you the problem. It's up for you to just listen and not ignore it. The signs are right there. So, the personal relationships you develop with patients, being nice to them, look them in the eye, listen to them, ask questions, do all that before you go to the MRI and the X-ray and the exam and all the things you learn in medical school that you want to get into and try to figure it out real quick. If you'll listen to the patient and put their priorities first, patient first, I think you'll come out ahead in the end. That's what I would tell young guys.
Man, that's phenomenal advice. I appreciate those words. And you breezed through it a little bit, but can you give us a little more info on some of the mentors that you had? You worked with the guy who did the first Tommy John's procedure?
Yes, that was Dr. Joe. Phenomenal man, and just a gem of a person. Yeah, he invented it at Kerlan and Jobe, where I did my sports fellowship. He is the Jobe of that. He invented the Tommy John surgery that is now, the mainstay really of professional baseball. I think I just saw that this morning. I was just reading the White Sox have 6 or 7 guys that need Tommy John surgery on their pitching staff this year. So now that's sort of mainstay. But at that time, of course, it was, he just came up with it, thought it would help, and figured it out on his own. It's just remarkable when you hear his story to tell about it. And I don't do it justice when Dr. Jobe tells about it. But, and then all the guys at Kerlan and Jobe, tremendous guys, Neil Elatrosh, who is currently the team doctor for the Dodgers and the Rams, and all the other guys at Kerlan and Jobe, Dr. Mike Maloney at University of Rochester, who also did his sports medicine fellowship at Kerlan and Jobe. He's the one that first really taught me how to do arthroscopy. Was another close mentor of mine at University of Rochester. Again, it's like I feel like I'm sort of doing getting an award at the Grammys. You're trying to go through these list of people that have helped you over the years, and you always skip over people. But again, my training both at University of Rochester for my residency, and then my sports medicine fellowship training has been nothing but the best for me, and it fit every criteria that I needed. And there was a tremendous amount of learning, both inside the operating room and outside the operating room, that you can use every single day.
Yeah, that's I wanted to touch base on it largely because I don't think that we give it enough credit and that we advertise it enough here at Aptiva as to all of the mentorship that you had over the years to make you the surgeon that you are. We get such good feedback and reports from patients, and some of those opportunities you had, those weren't just, they're taking 100,000 people a year or even 1,000 people a year. They're taking less than a handful of people for those fellowships, and for you to get in there, that's a big pat on the back to you too. So congrats on getting there, and two, thanks for choosing us at this point in your career.
Well, I appreciate that, and you were talking about, a mentor. Another great mentor is Dr. Ken DeHaven, one of the grandfathers of sports medicine. And he was at the University of Rochester. He was back doing arthroscopes when they would look through the keyhole, and back in the old school days, even way before me and you. And one of the things that Dr. DeHaven used to say, which I think is crucial, we can talk about 85% of rotator cuffs get better, or 92% of total knees do better, or whatever it is, whatever number you quote, whatever research article you read, and you can read whatever and come up with multiple numbers for whatever procedure, the outcomes, the prognosis, however you want to look at it. But really the only number that matters is the one that's sitting across from you in the clinic room. If the rate of infection, for example, so you have an infection and it's 1 in 1,000. So 999 people never get an infection, but if the gentleman across from you has got an infection, for him it's 100%. And so the key thing is when you got to take everything one-on-one, and look. And one of the things he used to talk about too was outcomes. I mentioned briefly talking earlier about having different procedures and different implants and different surgical options to treat something. Well, one of the things Dr. DeHaven used to talk about was really the outcomes are only as good as they are in your hands. And that you have to be honest with yourself. If you are treating someone and you're treating it and you get good outcomes and it's working well and you're doing it or better than what's considered sort of the standard of care, then you're doing well. I mean, maybe you don't need to change your surgical approach. However, if you're being honest and you're really following your own outcomes and there are better options out there and your procedures are not catching up to those standards that everybody else is, maybe you should try something different. But you can't know that just by reading an article and say, I'm gonna go back and do the old school way, or I'm gonna try this new way, without knowing exactly what you can get accomplished with your patients with being an honest outcome in your own practice. And that's I think that's the advice that is crucial.
And I can see where that would be key, and I can see where it'd also be easy, especially as a young surgeon. You do something a few ways, you do something one way, you get a few different outcomes, and then you start to wonder, like, maybe I need to mix this up, maybe I don't. And so I can see where it'd be hard to, one, stay steady with what you got, and then continually ask yourself, is this working or should I make a change? And then two, when it is time to make a change, knowing which change to go. I'm sure you could be in limbo, wondering, like, am I doing good enough by my patients? Am I not? I mean, do you see that a lot in orthopedics across the board? Like, are there other surgeons who get lost in that little window of wondering which direction do I go here?
Well, I think all of us as surgeons want to try to get every good outcome you can get. And one of the things you mentioned is, as a younger surgeon, but same as an older surgeon, if you do four procedures and one of the four is not as good an outcome as you want, you're out. I mean, I wouldn't necessarily say that you're 75%. You need to do, 150 of them and see if 75% of them are not doing well. You can't, what I'm saying? You have to have an N, in research. Your N is how many participants or how many people you studied, and to give it power to your research article. Well, if you've only done a few, you have to be patient, be critical, and of your procedure and your technique and what you read, and then thoroughly evaluate outcomes. You got to have enough surgeries under your belt using a procedure or using an implant or whatever to really make it matter. But at the end of the day, though, every surgeon that I've ever known, when they don't have the outcome they want, particularly a patient doesn't get the outcome they want, they don't like it, and sometimes more often than not, you look introspectively and say, could I have done better?
Sure.
And then start falling down an algorithm of how we can get that improved.
Mm-hmm.
I think that's human nature, but I think that human nature is probably a little bit more pronounced in healthcare, definitely when you're operating on someone.
Sure. Yeah, I can definitely be sensitive to that. We have the same feeling with therapists in regard to patient not getting better. We want to look at ourselves and think, what did we do wrong? What could we do differently? How could we have helped them better? And like you said, keeping the patient's focus as your primary concern and helping them walk through that, is just as valuable. So it seems like there could be it could be a very stressful thing to be an orthopedic surgeon. So what do you do to unwind? You got to break some steam sometimes. Like, what does it look like when Dr. Smith lets loose?
When I let loose, well, that part maybe is for a different discussion, but for here, anytime, outside of work life that you can prioritize time with family and friends is definitely at the top of my list. And then Jennifer and I, my wife, we live on a farm outside of that. So anytime outside family, friends, it's usually spent on the farm, going out to dinner, with a lot of sporting events, following all that, and spend as much time we can in that circle of activities. For years, up until the last year or so, I coached, and those of you who coach sports, and I coached baseball, basketball, football, cross country, all kinds of things for the last 20, 25 years. That was a tremendous kind of a opportunity to invest in young people and keep your tank full outside the work place, as you mentioned.
Mm-hmm.
But now as you get older, I'm not coaching as much now, more farming. My two kids are in college, and they, we go visit them and take care of, all those parental duties, and just spend as much time as I can with my family and certainly with my friends.
No, that's awesome. Yeah, got to have that chance to unwind. You'd mentioned coaches, and you mentioned something to me one time, and I'm sure I'll biff it. But you were talking about pain being an indicator for the athletes. So is there a message or anything as far as, talking to coaches out there, if they have an athlete who has some pain, like what would you recommend they do? And at what point should they look towards an orthopedic surgeon or even just a consult?
Well, that's a great question, because there, in sports medicine, there's a big difference in soreness and pain. If those of us who played sports long enough, I don't care what sport it is, you play long enough, you're going to get sore. Something's going to be your back, your neck, your shoulder, whatever. Soreness is a little different than pain. Pain itself prevents you from performing to the level you want to, or prevents you from even participating at all. And I think coaches who've been around it long enough, and and trainers, when they see someone who's trying to work through soreness with trying to compete and still competing at a high level, but is still sore, that's probably a little bit different than pain. When you have acute pain that causes inability to participate, or weakness, or instability, or something that keeps you off of the playing field. Like here locally, when we take care of our high school or middle school and high school and college kids, they want to play. If they can't play, for whatever's reason, whatever's bothering them, keeping them from participating, it's probably worth at least noting and maybe needs to be checked out. So they're trying to learn the difference between soreness and pain and how that affects them functioning off on and off the court or on and off the field, pretty much is a decent indicator of whether or not they need to come in.
Yeah, that's great insight. Like you said, we all have some aches and pains that come up when we're playing, but at the point of which you can't perform or you try and it's just not there, it's time to get it looked at. I love it. I appreciate that perspective. Dr. Smith, I'll always love talking with you. I appreciate you taking the time out of your schedule to block this off for us. Do you have anything in wrap up here that you'd like to share with us?
Not in particular. I mean, I appreciate the opportunity to come and hang out and talk. You on your end of the spectrum, you mentioned one of the things that Aptiva does really well is the physical therapy component, of which you're the head of. Because, again, learning in my mentorship, there's not a good surgery that a physical therapist can't mess up. There's not a bad surgery a physical therapist can't improve. So, you know, it seems to me like it's the latter more often than the former for me. A good therapist can really take maybe a surgery that didn't go as well as you want, or a patient who's struggling, and get them to where they need to be. And one of the great things about Aptiva is the physical therapy department. And they can keep a lot of people out of the surgery. And for those that need it, and they get you through the end to the finish line. And that's probably the quality of the physical therapy department that you run doesn't get enough credit, but it is well-deserved credit. I mean, patients do phenomenal outcomes under your all's care.
Well, thank you. We appreciate that. And as you said earlier, I attest that to us having a linear goal in mind, that we keep the patient-centered focused. We lay out their goals from day one, and we do everything we can to get them back to it. So it's a joint effort, and we definitely appreciate all that you do on your end. And thank you again for taking the time. For everybody out there in Injury Insiders episode, we're wrapping up. Don't forget to follow us, like us, subscribe to us, check us out on YouTube. Look us out on Aptiva Health. Download the Herd app. It's a 24 access to an orthopedic consultation that can give you ideas on whether you need to go to the ER or you can come and treat with us here locally in the office. So thank you guys all for the time. We appreciate it.
Thank you.